Today, it's my honor to welcome Dr. David Cohen, an interventional and structural cardiologist, the Director of Clinical and Outcomes Research at the Cardiovascular Research Foundation, and the Director of Academic Affairs at St. Francis Hospital and Heart Center in New York. Dr. Cohen is an expert in health economics and outcomes research, and he has devoted his career to studying interventional cardiology devices and procedures. His research focuses on the application of formal cost-effectiveness methodology to novel interventions for cardiovascular disease, the extension of traditional cardiovascular outcomes research to include patient-centered outcomes, and the development and evaluation of tools for assessing patient health status and preferences. I had the privilege of being one of Dr. Cohen's mentees when I was a resident, and it's my honor now to welcome him to Grand Rounds. Dr. Cohen, thank you for being here.
Thanks so much, Sneha. It's a real pleasure to be here. Great to see friends. I hope there's some other friends in the audience. And what I'm going to be talking about today, despite the fact that I've spent, for the last 25 years, I've given grand rounds on cost effectiveness in interventional cardiology. Sneha convinced me to do a completely different talk today. So you guys are the pilot audience for potentially the new grand rounds for the next 25 years for me. We'll see. But we're going to talk about comparative effectiveness research, and in particular, whether there's a role for observational studies or do we always need to randomize. These are my disclosures. Now, I am nervous about this talk, and I'm nervous about this talk for two main reasons. Because I'm going to violate principles that you guys, revere here at Stanford. Number one is this guy who says that randomized trials are the only way to know the truth. And so I'm going to make Bob very mad. And then secondly, I'm not going to talk about coronary physiology, Bill. I'm sorry for that. So you're going to have to give me a pass on both of those things, but hopefully it'll be worth it for the rest. So I think everybody in med school learns kind of something about research design and about different study designs for clinical research. And we know they start with things like single case reports and case series, and then we have various retrospective and prospective observational studies. And for decades, hundreds of years, we recognize that the strongest evidence comes from randomized trials, either single or multiple large randomized trials is our strongest evidence. That's our gold standard. And I'm not going to say that's different. I'm not going to be that provocative. And our challenge when we're designing clinical studies is to match the study design to the research question, and try to do this in a timely and efficient and cost-effective manner. And that is what I'm going to be talking about. So again, everybody should know, why do we need randomized trials? We need, because they are really, they still are, and David and I were just talking about this before, the best technique for eliminating confounding and assessing a treatment effect. And the magic of randomization is that it, accounts for confounding that you know about, but it also accounts for confounding that you don't know about, which is, really, really critical. And the truth is that as we get better and better, and cardiovascular medicine is a perfect example of this, our relative treatment effects that we're interested in get smaller and smaller. It was, back 50 years ago, you could, test a therapy like thrombolytic therapy in acute MI and, think you were going to get a 40 or a 50% relative risk reduction in mortality. Nowadays, you're lucky if you get 15 or 20%. And the truth is that, only, randomized trials are really the only technique that can give you that level of precision that can allow you to confidently estimate treatment effects that are in that size, but you still end up with these enormous randomized clinical trials. And, the other real advantage of randomized trials that, again, I think is a challenge for me in giving this talk is that they're the easiest to understand, right? All the work is done up front by the investigators designing the trial, randomizing the patients. Then at the end of the day, you count up the bodies, you count up the events, and you do, a very simple statistical test, and everybody can understand that. And that is, again, I think is also a major advantage of randomized trials. But the other side of the coin is that randomized trials are not infallible. They're not infallible, but they also have a lot of limitations. They're costly. Although David just told me about one he's doing for $440 a patient, so maybe you're going to figure out how to make them much less costly, which is great. They tend to, in general, have narrow inclusion and exclusion criteria, which raise questions about generalizability and transportability to other populations. Many trials that go on have a lot of protocol-driven care. For example, in interventional cardiology, we had a long period of time where we were doing trials where we did angiographic follow-up. The patients came back, and that induced a lot of effects that might not otherwise have happened. Very, very critically, the vast majority of randomized trials address exactly one question. You get one test. If you read the New England Journal of Medicine, you get one p-value these days, and we have a lot of questions that we want to answer. And then one of the real challenges, I think, with randomized trials is obsolescence. And this is, again, if you're working in a field like interventional cardiology or EP or heart failure, I mean, things change quickly these days. And if things are changing very quickly, randomized trials may not be ideal because everything is changing underneath them. And this is very, particularly true when the enrollment is slow or the follow-up is long. And so here's just an example. This is the Barry trial, the first randomized trial of PCI versus bypass surgery using balloon angioplasty. This was done in the 1990s. This was published in 1995. Showed the results. This is the repeat revascularization rates with PCI versus bypass surgery. You can see there was about a 40% absolute risk reduction. Fast forward, 4 years after this was published, we have stents now. Stents had reduced restenosis, and so a new trial was run called the ARTS trial. Again, it was just with bare metal stents, and that's shown in the blue curve, and the bypass arm is the white curve. And so that difference that we had seen in 1995 was already halved. And then the orange line there is with drug-eluting stents. This was a registry. It was a single-arm study with the same exact inclusion-exclusion criteria. So there are some issues with that comparison. But again, look how narrow that difference is. And this is just over the course of about 8 years that you saw this level of difference. And this really is a challenge for us, again, in rapidly advancing fields. Now, what about observational studies? I'm going to kind of walk you through all this stuff, but observational studies, we know what the strengths are, right? You can rapidly enroll large numbers of patients, and because of that, you can think it can be more flexible and accommodate changes over time. Nowadays, with all the EMRs that everybody has in electronic databases, there's the data. These kind of data tend to be ubiquitous. In that sense, they're much less costly and time-consuming than randomized trials. And you generally have very broad inclusion criteria, so you're not restricted to really understanding a very narrow segment of the population. But major limitations. Number one, if you're doing stuff in EMRs or claims data, the data quality is often poor and incomplete. One of the big challenges we have with observational studies is the lack of a unique time zero. Randomization, in addition to all the other benefits with regard to confounding, gives you, here is time zero, the time when you flip the coin and the patients were randomized. And this is especially difficult if you're trying to study something like we were trying to do an observational study recently looking at Watchmen. And, I know when the Watchman goes in, but I don't know when the Watchman didn't go in, right? So how do you find a time zero there? And so, again, there's tricks that you can use to try to do this, but it is a challenge. And then confounding, of course, because again, observational studies are based on what patients' treatments they get. And those are done very intentionally. And so we have to think very long and hard about that. And here's just an example just to show you how tricky it is to find the confounding. So this is a study that was published in the 2008. This came from the New York State PCI and bypass surgery registries. So they're clinical registries, and Ed Hannon is a smart statistician who did this analysis, and propensity match these patients out to yin yang using all the variables he had in the data set. And these are the findings with significant survival benefits of bypass surgery compared to drug-eluting stents for 3-vessel disease, even for 2-vessel coronary disease. And this is a relatively short time frame. They continue to widen over time. And the question is this real, or is there some sort of confounder? And remember back again, you probably learned this hopefully in medical school about what is a confounder. It's something that both causes the exposure and causes the outcome. And what it does is it distorts this, the association that you're really looking for, which is between the exposure and the outcome. And so where is the confounder in Ed Hannon's study? Took a little bit of time for people to figure it out, but one of the big confounders there is surgical eligibility. Only surgically eligible patients get bypass surgery, but the PCI group has people who are and are not surgically eligible. And surgical eligibility absolutely affects the revascularization strategy, but it turns out it also really affects the outcome. And this is work, This is work that was done a couple of years later. This is Bobby Ye and Steve Waldo looking at surgical ineligibility at Mass General Hospital and Brigham and Women's Hospital. And these are the survival curves for patients who were getting PCI, but were surgically ineligible, which is shown in the dark line, and ineligible shown in the dashed line. And you can see, just huge effect on mortality just because of surgical ineligibility. And then if you look to see, do we collect this information in the registries? We don't. A lot of the things that drive surgical ineligibility, poor conduits, never see that. Poor targets, don't see that. Viable, non-viable myocardium, that's not in our registries. Cachexia, chest wall abnormalities, there's a lot of things that drive whether patients are surgically eligible or not that are simply not captured. And so this really is, again, one of the classic challenges when we're doing observational studies. So, the question for us here in 2024 is there any solution to this shy of doing big randomized trials for every single question we want? Can we make a better mousetrap? And there's a number of things that we can do that I'm going to try to talk about in the next 30 minutes or so. Pre-registration, talk about that in a second, and falsification endpoints. Those are two things you can do, for every single observational study that's ever done, but are rarely done. And then I'm going to spend most of my time talking about quasi-experimental designs, things called instrumental variables, difference in difference, regression, discontinuity. These are all techniques, and they all come from economics, actually, is where they started out, where it's hard to do randomized trials. And then finally, a technique I'm not going to cover today called target trial emulation. But let's, just talk briefly about a couple of those things. Pre-registration, this is routine in randomized trials, right? You say, you write down the whole protocol, you put it up on clinicaltrials.gov these days, so everybody can see it, and you kind of, you say, here are the rules, and we're going to follow these rules, and this is what we're going to, study, and that, protects you and protects the, the audience and the consumers from, p-hacking, from people, looking around for an endpoint that shows the thing they wanted to show. So again, writing everything down ahead of time is very, very helpful. And again, it's commonly used for randomized trials. It's actually commonly used these days for meta-analyses, but for some reason, there isn't a website, at least that I'm aware of, where people routinely register their observational studies, and we probably should. And then the other technique, which again is underused, even though it's not hard at all, is the idea of falsification endpoints. And so falsification endpoints are, a way of looking for unmeasured confounding. And the idea here is to figure out an endpoint that simply should not be affected by whatever exposure it is you're interested in studying, and then using the same analysis that's being used for your target endpoint, do that with this falsification endpoint. And if you see a difference, that's pretty good evidence that there's some form of unmeasured confounding, because again, there shouldn't be. And just as, a couple of examples, so we've done studies looking at, transradial versus transfemoral PCI. And the primary endpoint there has been generally, a lot of the studies, at least for like meta-analyses and observational studies, has been in-hospital mortality. A nice falsification endpoint for that is non-access site bleeding, because, whether you go in through the wrist or go in through the leg, it shouldn't affect their risk of GI bleeding. And so that's a nice, way of thinking about it. If you wanted to study transcatheter versus surgical aortic valve replacement in an observational fashion, and you wanted to look at 5-year mortality, falsification endpoints ideally would be something that maybe is associated with different measures of frailty that don't show up in the database. So things like being hospitalized for pneumonia or a hip fracture, things that frail people do more than not frail people. So hopefully that gives you the idea. And again, these are not that hard to implement, but if you look at the observational literature, it's actually pretty rare that people actually take the effort to do this. Sometimes it's due to data limitations, but I think a lot of times it's just due to, they aren't really aware, or maybe they did do it and they didn't find what they liked and they hide it. That's also possible. Now I want to switch gears, and again, I'm going to spend the next 30 minutes or so talking about what I think really is the best way to conduct observational studies in 2024. And I'm going to show you some examples that we've done over the years, and hopefully get you guys thinking. And I might call on the fellows, or maybe Doctors Marin and Fearon, to help answer some questions here. And we're going to talk specifically about interventional cardiology questions. So the first one I'm going to talk about, this is the first meaningful observational study that I ever did. And it's got an interesting backstory that I'll come to in a second. But we were interested in timing of cath for patients with non-ST elevation myocardial infarction. We know our guidelines say early, right? They say, early cath, early invasive strategy for patients who have biomarker positive ACS. And that's what the guidelines recommend, but nobody really says what early means. right? Does it mean 24 hours? Does it mean 12 hours? Does it mean treat them like a STEMI and get them, in 90 minutes? We simply don't, we don't really know ideally what, what the truth is there. In the early 2000s, early in my career, a trial came out from Germany called ISAR-COOL. And this study was one of the first studies to try to randomize patients to different timings of invasive management. You can see here the strategy on the left. They took 410 high-risk ACS patients. They treated them with state-of-the-art medical therapy, including dual antiplatelet therapy and heparin, and actually a 2B3A inhibitor. And then they randomized them to either, immediate cath and PCI, basically within 3 hours, almost STEMI level management, or to a prolonged cooling off period, which was like, putting them in a room somewhere for like a week. And then they looked at a primary endpoint of 30-day death or myocardial infarction, and they published in JAMA these results with a, near 50% reduction in that primary endpoint that occurred within the first 7 days or so. And so that was at least one answer to the question. But the truth is that's it's a small study done in Germany, and I don't think it really answers the question that we have here in the United States, right? This was a highly selected patient population. The crossover, you couldn't, like if somebody was in that study and they were in the conservative arm where they went, were supposed to go in a very delayed fashion, you could only cross them over if they'd already had an event. So you had to watch a patient have, multiple episodes of recurrent chest pain or things like that, and you weren't allowed to cross them over unless their troponin became positive for that. And so, and again, the timing is, not relevant to the United States. An 86-hour, delay in time to cath for patients with ACS, nobody's going to do that. We would rather know how does 3 hours compare with 24, or how does 24 compare with 48, something like that. It wasn't powered for, really meaningful endpoints like mortality. And raises the question of whether a study like this with all these limitations should be changing our guidelines. And so if you were going to do this as an observational study, if you were kind of coming to this de novo, this is probably the way most people would design an observational study to look at this question. They would take a registry, a clinical registry, so we have good clinical data of real world ACS patients. They would be managed by their physicians, however they thought was appropriate. And then you would separate them into patients who had a relatively urgent cath within the first 24 hours, and those who had an early cath but not quite so urgent. And then you'd look at an endpoint, then you'd risk adjust it, right? You'd either do regression modeling, or you'd do propensity adjustment, some factor that would allow you to kind of balance the scales. But the problem here is, again, first of all, the selection bias of who gets which treatment, which means that risk adjustment is essential, and you need to account for everything, including the unknown confounders. Secondly, is it's not prospective, right? You only know who these two groups of patients were after everything has already happened, which is not the way we treat people. And again, it's impossible to adjust for unmeasured confounding. And so we were interested in trying to study this, question, or we became interested in it. So now, do you know this guy? Anybody know this guy? David? Nobody? So this is why, why is this guy, and who should you care? So this is Josh Angrist. And Josh Angrist is an economist who won the Nobel Prize 3 years ago for basically inventing the methodology we've just been discussing, which is instrumental variable analysis. He was for methodological contributions to the analysis of causal relationships. And this all came out of economics because, again, in economics, it's not easy to conduct randomized trials, although people are starting to do some of that. But this really was, the whole technique and the math behind using natural experiments like the day of the week to study causal relationships in complex economic systems. And that is really what we're going to talk about for the next, the next period of time. So, again, the idea here was to use my, my residents' insight about the difference in the timing, and to take advantage of that as a natural experiment, because people generally don't get to pick what day they show up in the hospital for their MI. So it's a quasi-randomized design. And again, an instrumental variable is a factor which is correlated with the variable of interest, in this case, the delay to cath, and is otherwise not associated with any other relevant patient characteristics or treatment variables. So it's got a bunch of assumptions, and you have to understand those assumptions and verify those assumptions. And the challenge here is, can we identify them? And I forgot your name already? Neil. Figured it out. So this is the paper we published in Circulation, looking at early versus delayed cath non-ST elevation MI. We started with 77,000 patients in this registry. We excluded a bunch of patients who came to hospitals that didn't have cath labs. We ended up with 56,000 patients with high-risk unstable angina or non-STEMI. and then we broke them out by weekend versus weekday. So about 10,000 patients in one, and weekend was Friday 5 p.m. to Sunday at 7 a.m. Because again, we're looking at sort of what was the day after the weekend, but we actually varied that in a bunch of different sensitivity analyses. And so the question is, the first thing you have to ask is weekend presentation an effective instrumental variable? It makes sense. You came up with it, spontaneously. Remember, this is the conceptual model of what an instrumental variable is. So if we just look here, you can say there are three assumptions. One is this relevance assumption that the instrument has to have a causal effect on the exposure. It has, day of the week, in this case, has to change the time that patients come to the cath lab. Not a very far leap, but something we can verify. It has to be independent, meaning quasi-randomized, meaning that the patients, there's no other factors. It doesn't, correlate with any confounders. And just so that's the relevance assumption. Number two, it's not correlated with any confounders. And number three, the instrumental variable, the day of the week, can't drive outcomes through any other mechanism other than the time. Now that is an assumption. That is not completely verifiable. You can do some tests around it, but it is something you have to think about and convince yourself that it is true. Otherwise, you're not meeting all of the IV assumptions. So let's look at those assumptions in this particular study. So here are the baseline characteristics between weekend and weekday, and it probably wouldn't surprise you to see that they're absolutely identical. Patients don't get to choose what day they show up in the hospital having a heart attack. And we had hundreds of other covariates. They all are very, 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 very similar. So this independent assumption that it's good as randomized is probably true. What about the processes of care? So this is looking in the first 24 hours at the different meds and things like that they got. And again, here, whether you look at aspirin, beta blockers, 2B3 inhibitors, whether they eventually went to the cath lab, and whether they eventually got revascularized, all again equal. So this really tends to support that exclusion restriction, which is the third one. This is not provable, but this is pretty damn supportive that there wasn't anything else going on that day of the week was really influencing. Oops, let me go back here. Sorry. Come on. I thought I had one more. Did I miss it? Sorry, maybe I didn't. And then finally, here is the last one. And the last one is, did day of the week differentiate time to cath? And what we show here are continuous distribution curves showing time to cath for the people who eventually did go to cath by weekend, weekday, time to revascularization. And what you can see basically is it worked very well. So the median time to cath in patients who came during the weekday, 23 hours, weekend, 47 hours. Look at time to revascularization. It was a little longer because of some delays to people undergoing bypass surgery, but there's very, very good separation between those two. So we've got a good instrument here. And so what did we find? This is what we found. So this is the simple comparison, which is revealing in and of itself. So this is just looking at the people who came on the weekend versus the people who came during the on the weekday, and there was no difference in hospital outcomes at all between these people who had this big difference in the time to cath. And then if we looked at the instrumental variable analysis, which goes another step where we're using more math, this is really the stuff that Josh Angris developed of two-stage regression models. You can see here, depending on how we defined early cath, whether it was within the first 12 hours, 24, 36 hours, there were trends towards differences, but in no cases were they at all statistically significant. And so we were, pretty happy with this. And my med student or my resident got a very nice circ population out of it. And I think it made me a hero with all the interventional cardiologists because now they don't have to come in and give up their golf game on the weekend to come cath this guy who showed up with chest pain, but now it's chest pain free and just has a positive troponin. He can wait till Monday. So again, I think just a nice example of what you can do if your eyes are open, you're thinking like an economist about how to study these questions. And why are the results different? There's a number of reasons why the results are different from that randomized trial. Number one, probably as important as anything, is how much narrower our time window was. It wasn't a 60-hour difference. It was a 24-hour difference. And it's really in the time frame that's more relevant to U.S. practice. Nobody's going to wait 86 hours. Very, very importantly, we didn't have this artificial protocol of you can't go to the cath lab until you've had an event if you're in the conservative group. In fact, 9% of patients in the weekend group went to the cath lab within 6 hours, and 17% went within 24 hours. And so these people were crossing over, as it were, because that's how we manage patients. We don't religiously, we stick to a strategy. And so we were allowing the care to evolve in a more natural way. And it's very likely these patients were being selected because they had ongoing symptoms or something like that, and it helped. And then finally, very importantly, because this was observational, we didn't have a protocol for saying we're going to check the troponin, every 6 hours or something like that, really looking for small infarcts. This was all clinical. We used mortality as opposed to a composite endpoint that was entirely driven by myocardial infarction. So there are important differences. But the biggest important difference is you have to keep in mind that these different techniques answer different but related questions. So a randomized trial addresses a specific clinical question for an individual patient, but it answers it in average. It says, what is the average benefit of performing invasive therapy at 24 hours compared to 48 hours for a typical patient with non-ST elevation ACS? That's kind of your randomized trial design. The instrumental variable question technically is answering what I like to think of as more of a policy question. It would be, what would be the effect of a policy that said we're going to staff hospitals and run them like we don't care what day of the week it is? It's absolutely agnostic to day of the week, and that reduced the average treatment delays by 24 hours for everybody who came in with a non-ST elevation MI. It's a different question a little bit. Both are relevant. Both are clinically relevant, but they're not answering exactly the same question. So that's something also to keep in mind. So let me go on now to another example and show, again, and we're going to have to let somebody other than you think about it because you're going to figure this stuff out right away. Actually, you might not figure this one out. We'll go at it for this one. Because are you an interventional fellow? No. What are you? Okay, sorry. So you won't know the answer to this one. So we'll pimp you on this. And then we'll go to somebody else for the last one. So a question comes up: do drug-eluting stents save lives? Everybody knows drug-eluting stents. This is a pig's corner right on the top with a bare metal stent, and on the bottom with a drug-eluting stent. They work, right? They reduce restenosis, they reduce neointimal hyperplasia, they reduce repeat revascularization. And one of the questions that came up in this sort of first 5 years of their introduction in the mid-2000s was, do they save lives? And it was actually kind of came up the other way around, like, are they killing people? Because there were concerns about thrombosis and late thrombosis that happened, but none of our trials that we had done up to then, and we'd done a lot of trials of drug-eluting versus bare metal stents, were powered to look at mortality. Now we had some data, but people, said, we're going to do observational studies of this. We've got good registries for PCI. And this is a very smart woman. This is Laura Morey, who was a colleague of mine at Harvard for many years. And she used the Massachusetts PCI registry to do this comparison. Published this in Circulation. She actually had a companion one that was on patients with STEMI. It was published in the New England Journal of Medicine. They showed exactly the same thing, which was that after doing propensity adjustment and accounting for about 90 different variables, there was a highly statistically and clinically significant difference in mortality, lower with drug-eluting stents than bare metal stents. And there were literally like 4 or 5 other papers published right around this same time that all said the same thing. And we said, I don't know. It doesn't really make sense. And part of the reason it didn't make sense is we actually had some data where there were meta-analyses of the trials that existed at that time, which had about 5,000 or so patients in them. And this is a pooled analysis, bare metal stents versus one of the drug-eluting stents. Doesn't look very different to me. Here's a meta-analysis if you like those. And the pooled effect size is right on the unity line. So there was some disconnect here. What's going on? Even though, again, these observational studies were being published and they were being discussed as though they were, the real effects. And so, you ask yourself, like, why do these results differ so much? And one of the hypotheses, what most people wrote in their discussion sections of the papers that showed these mortality benefits, was its differential performance in the on-label patients who were in those randomized trials versus the broader population of off-label patients who are more complex. The other alternative is its unmeasured confounding, despite the fact that they did the very best they could using clinical data to do the risk adjustment. And so how are we going to sort that out? And so, we wanted to do this study and to ask the question, is there a survival benefit with drug-eluting stents in the real world? But we want to try to really get at it in a causal way. So any ideas here? Like I said, I don't think you're going to get this one. So that one didn't work because everybody was using it almost the same. It was like, 90% every hospital.
The only thing I think of is regression. Some guidelines came out, and then suddenly the use of drug-eluting stents.
Smart guy. He's a guy. So you nailed it. But again, there's a good backstory on how you nailed it. So, regression discontinuity is something where there is just, an arbitrary event of some sort, or it can be, again, there's a lot of people do these like last digit, studies where they look at the difference between managing people who are 79 and 80 years old because suddenly they feel like they're very different even though they're not. Those are all regression discontinuity, and that's what we did here. But it's really interesting how we did this. So this is a registry that I ran called the Event Registry. It was a registry that we ran. It was actually sponsored by one of the drug companies because we wanted to look to see if there was still prognostic significance to peri-procedural MIs in patients undergoing PCI. And the way that we ran the study was we did it 50 centers across the United States, and we did 2,500 patients a year for 4 years running. That was the way that we did the study because we didn't have an infinite amount of money to do this for it. And the idea when we started it was to do what you said, which is to look actually at because drug-eluting stents were approved in the United States in 2003. And so we figured there'd be a ramp up and we could use that ramp up to kind of look at different rates of use of drug-eluting stents. The problem was lawyers. So the lawyers took so long to sign the contract for this thing that instead of starting in 2003 when there was a ramp up, we started in 2004 and it was done. There was already, by 2004, drug-eluting stents were being used in 90% of all the patients undergoing PCI. But we lucked out because in 2006, at the end of 2006, there was this so-called drug-eluting stent firestorm where people started raising questions about these excess thrombosis events, and suddenly there was a big drop in the use of drug-eluting stents. So we lucked out. We didn't get it on the way up, but we got it on the way down. And so this is, if you look just naively and you did an observational study, this is the bare metal stent versus drug-eluting stent baseline characteristic comparison in these 10,000 patients collected over 4 years. And you can see standardized differences on the right, and usually a standardized difference of greater than 10 is a clinically important difference. And you can see there's all kinds of differences between patients getting drug-eluting and bare metal stents. And that's the first thing that should tell you that a conventional, observational study isn't going to get this right. You can see, again, there, just all these big differences. Here are differences in the indications for PCI. The bare metal stent patients were more likely to come with ACS. They had lower GFRs. They had lower ejection fractions. They were higher risk for clinical events. On the other hand, the bare metal stent patients had more favorable angiographic characteristics because that was where people were willing to use them. Less LADs, shorter lesions, larger vessels, all of those sorts of things. So there were all of these differences, and there probably are things we can't see either. And that's really is the problem. We could adjust for all these things. We can see them, but we don't. But there's a lot of other things we don't see. And if we did the naive look, if we just did, this is just the unadjusted outcomes, target lesion revascularization or restenosis on the left, what we expect, lower with the drug-eluting stents. And on the right is basically what everybody else was publishing in some version, which is excess mortality with the bare metal stents that we know is being driven by a lot of factors. So we have to risk adjust this. And so here's the natural experiment. This is what you were talking about. This is the regression discontinuity. So for 2004, 2005, 2006, 92 to 94% of all patients treated got drug-eluting stents. And then bang, right at the end of 2006, these papers came out and it dropped immediately to 73%. And we said, aha, we've got our moment where we can seize on this because again, it's unlikely that the patients who are being treated themselves would change over time, but the treatment pattern changed abruptly. And so that was our moment of revelation. Here, we can divide them into this liberal use period and this more selective use period, and we can compare outcomes functionally between the liberal and the selective use. And now, if we look at the liberal and the selective eras, you see the exact opposite of what we had seen just drug-eluting versus bare metal stents. All the clinical characteristics are the same. All the indications and imaging characteristics are the same. No differences in angiographic or clinical characteristics. And here are the outcomes when you compare 2004 to 2006 drug-eluting stents versus 2007 drug-eluting stents. You still see a difference in repeat revascularization because the drug-eluting stents do what they're supposed to. But now the mortality is dead even. And when we do this with the appropriate analytic techniques, which are basically the same ones that we use two-stage regression for the instrumental variables. If you look at the conventional way, so the way that everybody else had done this study up until this point. You can see here, if we did multivariable regression and you look at the mortality, data here, significant reduction in mortality when we did conventional risk adjustment. If we do propensity matching, again, a significant difference in mortality in favor of drug-eluting stents. But when we did the regression discontinuity or the instrumental variable approach, nothing. Mortality was absolutely equal. If anything, it was slightly the other way around. The bare metal stents were doing a little bit better, but it's not at all significant. But we continue to see this difference in target lesion revascularization. So again, to me, this was, really very, revealing study that we could replicate what everybody else found. But when we did the analysis in a more sophisticated, more appropriate way with a quasi-randomized design based on this regression discontinuity, lo and behold, that, mysterious, unexplained effect that nobody would have expected went away. So, and then 5 years later, we published this in 2011. I'll skip through this just for time. This study was published in the New England Journal of Medicine from Norway, the NORSTENT trial, 9,000 patients randomized to drug-eluting stents versus bare metal stents with a primary endpoint of 5-year mortality. And lo and behold, nothing. So we found this 5 years before they found it using, a very, a convenient time point that just happened to happen because of, again, some accidents in history. Not bad. For that. Now coming to the last one, we're not gonna have you on this one, because you know all the answers. I need you to come work with me. Actually, is what I need. This is a really interesting one. So this is cerebral embolic protection for TAVR, and this is the device. It's called the Sentinel device. It's approved in the United States. Stroke is still a problem with TAVR. It happens in about 2% of our patients, and it's devastating for the patients who have a stroke, especially if it's a disabling stroke. Very severe clinical and economic consequences. And so that led to the development of these devices, which essentially this one is a filter. One limb of it is deployed in the innominate and the other in the left carotid, and so it protects 3 of the 4 great vessels to the brain. And it was approved in the United States in 2017 on the basis of several small randomized trials that used imaging endpoints. And in fact, the primary randomized trial in the United States that led to its approval didn't even meet its primary endpoint. Okay, so it was approved on what I like to call the grandmother principle. What would you want for your grandmother if she was having a TAVR? I'd like to have this. Does it work? I have no idea if it works. Are you guys using them, Bill? Selectively, okay. Do you know what your proportion is at this point?
But probably 10%.
Okay, so very selectively. Okay, like bicuspids and horrible aortas or something like that. Yep. Okay, so that and that's not an uncommon answer, although that's the minority of the answers still in the United States. So we said, we want to know this answer. There were randomized trials that were being planned, bigger ones, but they hadn't happened yet. And so we said we're going to try to look at this using the TVT registry. And so any interventional fellows who want to hazard a guess of how to look at this study using data from the TVT registry, which is our national registry that collects clinical data on every single patient having TAVR in the United States. Jan? This is my friend Jan Peach here, who's a decision analyst and health economics guy, but I invited him special because I thought he would know the answer. You have any idea? You didn't know I was going to call on on all friends. You don't have to? We got a volunteer. So you're close. Actually, the way he mentioned is a way that we would do it. We would take advantage of variation at the site level in what's happening, because we know there are sites that are like Bill here that are using it selectively. We know there are sites that are using it none, like the place where I was working when we started to do this study in Kansas City. And then there are places that use it all the time, like all the hospitals in New York City, for a variety of reasons. Litigious people. You want to be one up on everybody else, down the road. And so that is the instrument that we used here. And this is the study. It was led by Neil Butala, who's now on the faculty at the University of Colorado, very talented observational research guy. And so we studied all the patients in the United States undergoing transfemoral TAVR 2018 to 2019. We pre-specified the whole plan, laid it all out, And the instrumental variable was the hospital's proportional use of embolic protection devices in the calendar quarter in which the procedure was performed. So every calendar quarter, we recalculated how often did they use it, because that is a very good way of predicting whether the patient's going to get embolic protection or not. We also adjusted for a patient and hospital characteristics to sort of doubly adjust this analysis. But the fundamental issue was using this instrument that was based on the site preference. And the reason why it worked, this is the population. So again, we started with 130,000 patients. We excluded about 10, leaving us with 120,000 patients. And over that time period, those 2 years, about 12,000 of them, about 10% got embolic protection, and the rest did not. But why this study worked so well is this. So this is every single hospital in the United States, the 600 odd hospitals doing TAVR, and the proportion during those 2 years that they used embolic protection. And you can see here, this is the perfect setup for an instrumental variable analysis. You have the control group all on the right, never used it ever, 0. And then you have, Bill, somewhere over here. And then you've got, like my hospital now in New York, way up there on the upper left. So where you go for your TAVR has way more influence on whether you get embolic protection than anything else. This is one of the strongest instruments I've ever seen for it. So it was perfect. And so here's our primary outcome using an instrumental variable approach, taking advantage of the site variation. 1.54% stroke in the patients who didn't get an embolic protection device, 1.39% in 120,000 patients. The relative risk is 0.9, and the confidence interval is not at all statistically significant. To me, that's a pretty convincing thing that if this either doesn't work or it works very poorly. It still is consistent with some possible benefit here, but it's not a lot for it if it's even true. And if we looked at a whole bunch of other endpoints, again, using this exact same technique, just highlighted a couple in black here, death or stroke, no difference. Major bleeding, which was our falsification endpoint, shouldn't be affected by whether you use an embolic protection device that goes in through the radial artery or not. No difference. So again, confirming at least one falsification endpoint showing no difference. Device success, which was our second falsification endpoint, whether they were in the high user group versus the low user group, did it affect the likelihood of getting the valve in well implanted without a lot of leak, without any major complications? No. So we've got two, pretty important falsification endpoints here. No benefit on 30-day outcomes, no benefit on 30-day death. 2 years later, 3,000 patient randomized trial sponsored by the company that makes the device, published in the New England Journal of Medicine, powered to detect a 50% reduction in stroke with the embolic protection device. Primary outcome, 2.9 versus 2.3%, P, not even on the radar screen at all. Now, there was this interesting finding, which they've kind of played up a lot, of a apparent reduction. This did meet statistical significance for disabling stroke. We're working on it for that analysis. But again, 2 years before the trial was completed, no benefit. Now, there's a second trial that's going on in the UK right now, which is the same company, same device, 7,000 patients they're randomizing, powered for about a 33% reduction in stroke. All we know about that one is they've enrolled like 70% of their patients. They've had 2 interim looks, and the trial is still ongoing. We'll see what we find. So to me, I think these are 3 pretty good examples, and they're not cherry-picked, believe me. They're actually just, I've done a few more. They all kind of go along these lines. Now, you're kind of thinking here like, wow, this is pretty cool. Like, can you always do this? And the answer is no, you can't. And there was a very nice study that my friend and colleague, Bobby Ye, published earlier this year in JAMA Cardiology, where he tried to look at Impella. So everybody knows Impella, a circulatory support device that's getting a lot of use in cardiogenic shock. Patients come in with a STEMI and cardiogenic shock. Default now in the United States is, you often will use an Impella device, but it hasn't been studied for that. It really doesn't have, again, it's kind of like the embolic protection story where it was approved with no outcomes data. In fact, it's never had a positive outcome study for anything. And so Bobby was commissioned by the FDA to try to get at this using observational approaches. And so he published this study trying to look at Impella and AMI cardiogenic shock using Medicare data. Now, it's kind of, that's like working with one hand tied behind your back, because Medicare data is, sort of the worst kind of observational data you can work with. But Bobby's a really smart guy, and if anybody could do it, I would say Bobby could. And so they did 4 different analyses. They compared Impella to either balloon pump or no MCS. They lumped balloon pump and no MCS together because there are randomized trials comparing balloon pump to no MCS showing no benefit. So they're both placebos. They did propensity score weighting. They did instrumental variable analysis based on the rates of use at the centers, like we did for the embolic protection device. They did a difference in difference analysis looking at rates of change of use of Impella across different centers. And they actually did a grace period analysis, which is a sort of a mock randomized trial. 3 of the 4 methods that they used suggested significant harm with Impella, and the 4th one said nothing. It was the confidence intervals were basically like 0.9 to 2, or it was like 0.1 to 2 or something like that. It was just a huge treatment effect. But then what they did that got this paper published in JAMA Cardiology was not those analyses. What they did was then they went back and they looked in extraordinary detail at the assumptions, and what they concluded, which I think was very fair, and we wrote the editorial with this, was that detailed examination of the data coupled with background knowledge of what actually happens in real life, the drivers of treatment decisions, suggested that in every one of these cases, some of the key assumptions that underlie that analysis were violated. And again, what's really important about these types of approaches is that they have assumptions and you have to check them. You have to really check them. And that's what a lot of people, don't really do. And so they basically concluded that we need a randomized trial. We're not going to get the answer to this from observational data. It's just there's too much. Ultimately, the treatment decisions are too strongly driven by a number of different things that are very, very difficult to measure. So let me have 2 final slides here. One is for those of you who are interested and think this is kind of cool. How do I become a better observationalist? How do we become Neil here, who's clearly got some real chops? The number one, you have to be a clinical expert. This is not, in my view, a pure methodologist is going to suck at this. Because you need both clinical expertise to understand the questions and the drivers of the treatment and all of those different things that somebody who knows the methods, Josh Angrist, this guy who invented all this stuff, is never going to be able to do this because he doesn't understand the clinical issues. So you want to understand the important questions, understand the drivers of treatment selection. And I think, again, like I said, clinicians are better positioned to do this than methodologists. Number 2, you still have to get methodologic training. You have to understand these methods, both to be a prepared mind to sort of see where these, experiments are, and then know what to do with them when they happen. And then you can also, an added benefit is now you can talk to the methodologists and they think you're smart. So that's, again, a good reason to get methodologic training. And then finally, observe. Keep your eyes open, look around, think about what questions are important. And when you see something like this, or you can think about, some of these issues, once you know how to look for them, they're not everywhere, but they're around quite a bit. And then also, be humble, recognize that not all clinical questions can be answered with observational studies. Sometimes all the stars align and you can get one that like the ones I showed you, which I think are really good examples, but there are a lot of places where you can't. So finally, just my take-home messages. Number 1, hopefully I didn't come across as bashing randomization. Randomization is still the gold standard, is still by far the best and most definitive approach to developing unbiased, reliable, evidence. And so when we have those, we have the money, we have the time, we have stable technologies, all those sorts of things, randomize away. But nonetheless, we're going to continue to have gaps in our evidence base where there are no trials, or where devices get approved when the trials are all neutral. Non-representativeness. We do a trial in a really slight, small slice of the population that we're really interested in and don't understand generalizability, or if we have, artificially constructed trial protocols with endpoints that are funny or with angiographic follow-up, things that just change care in ways that don't happen in routine practice. And hopefully, this, 45 minutes or so of discussion has really, showed you that with careful planning and careful analysis, we can learn a lot from observational treatment, comparisons to supplement what we have from randomized trials and evidence development. Certainly, the idea that observational studies are, hypothesis generating, that's great, but nobody uses them for that. I mean, we know the hypotheses. I think that's sort of kind of crap these days. What I do think is that with quasi-experimental designs like these, where we're taking advantage of some sort of natural experiment and then using, detailed data, clinical data, with, good measurement of exposures as well as outcomes, with appropriate caveats and with, careful validation of the assumptions, I believe we can actually provide causal inference that is valid for making clinical decisions. And again, I think these examples are them, but it still is caveat emptor. As I said at the very beginning, one of the real advantages of randomized trials is they're easy for everybody to understand. This stuff, maybe not quite so much, but hopefully this gives you a flavor of what can be done, and you'll be a better consumer of the observational data. Thanks very much.